I'll just take a few minutes, and what I'm going to do is try and bring Greg to life for you so you understand who he was, the kind of characteristics he had, and then by that being able to understand, in his case, when people come to us and say, oh, we've had that experience or this experience, it fits with this, although perhaps not to the same tragic end result. What you have on the screen there is my two daughters decided that they would develop a website, and you're certainly welcome to go to that. It has a more detailed description of Greg's journey, and it certainly has links to Dr. Flemons' report and a variety of bits and pieces of information as they come forward. So if that's of any use to you, and certainly if it provides a useful background, use it yourselves, pass it on, share it, do whatever you like with it, because that's what the purpose is. I have with me my daughter Terry, who is part of the process as well. So Greg was born April 5th, 1981 in Calgary, born and raised on the family farm, active in local community, positive individual, enjoyed things. There's the picture of the rest of his siblings. He had one older brother, two younger sisters, and a yet younger, the youngest member being a son. Although he's now 6'5", he doesn't really look like that in that particular picture. And he was really a positive, happy person all the way through his life. I guess I have to push it more than once. One of the things that Greg was pretty passionate about was his fitness and his involvement in sports. He played in he played hockey in these younger days. He was involved in all the sports through junior high and high school, and baseball being a favorite. Was involved in provincial championship teams and indeed in baseball, the Western Canadian. He came back to the community and coached also, so he did coaching both in basketball and in baseball. And he enjoyed sort of challenging himself to do more than the ordinary when he was out skiing, whether it was on water or on the snow. After he had finished high school and got out into the working world, one of his aspirations was to become a private pilot, so in fact he accomplished that and enjoyed that aspect as well. And family always was high on his list of priorities, and there's one of his oldest nephew. And he helped family in other things. I've got a brother that's pretty active in the cattle business, and so whenever they were short, in terms of manpower, he was more than happy to jump in and give a hand there. Picture of his graduation, he graduated from the University of Alberta as a mechanical engineer. His early work experience was in a local fabrication and design company. He moved on from that to work with Schlumberger on an international basis in the oil patch, and still wanted to come home and be part of the home community. He established, after working for a small oil and gas company in Calgary, decided to institute his own company to pursue one of the visions that he had that came out of his experience there. And that, for those of you that are familiar at all with the oil patch, with oil and gas, when it's produced, there's also water, in some cases produced along with it. Generally, that water is taken and pumped down a waste well, never to reach the surface again. Greg created a business around refining that water to greater than potable standards, and thought that would be a positive environmental thing to do. Unfortunately, he was ahead of his time, and the regulations in the industry and the economic view of the oil and gas companies at this point in time just weren't ready to take that, even though it was fiscally competitive with what they were currently doing. But that was something he tried for 2 years to get going, prove the concept, but wasn't able to actually get uptake so that it transitioned into what could be a successful enterprise economically. One of the things that Greg did through his time was that he was pretty concerned about, he always put others ahead of himself, I'll put it that way. And in the last 6 months or so, he was concerned about what he thought was an athletic injury initially, and it turned out to be more than that. He never brought his family or his friends into the picture until he was confident after receiving the final diagnosis of what it was. And so I put on the screen, there will be a couple screens here of the email he sent to the rest of us explaining why he didn't do that and how he felt about the sports that he had. So I think you probably have had a chance to read the first one. This next one's a little bit longer. Are you able to see that at the back? All right. So again, it's an example of his selflessness and his concerns for others ahead of himself. As health professionals, you also will appreciate that made him vulnerable. And ultimately, it was an unhappy outcome. So on May 16, 2012, he was operated on, had an orchidectomy. On Friday, we took him back to emergency because we were concerned with lower body swelling that was building up. He was told that everything was fine, he could go home, it'd be all right, and Saturday morning, he passed away from a blood clot. So some of the things, Greg kept a couple of books he called Greg's Everything, and in those we found afterwards some quotes. Last one reads, "My best friend is the one that brings the best out in me," for those of you that are having trouble looking over others' heads. So one of the things, just to sort of reinforce his character a little bit, at his funeral, there was a number of things that people spoke of, and one of the key ones was that he made everyone feel special. He obviously was honest, positive, respectful, strong, and exceptionally determined to make a difference. So that kind of puts you in the picture in terms of who he was. We're exceptionally, we really want to thank Dr. Flemons and the Alberta HQCA group for their interest and their courage in going forward, doing this investigation and producing a report that we believe is a really solid platform on which change can be built. The expert aspects of their investigation and the reporting, as a family, we think provide a very compelling platform for change. That's what we want to see. We want to see meaningful change on fronts that are really fundamental. Quite honestly, from my perspective, out of the farming and food business, I appreciate the comments that were made earlier, but and I understand the complications that your world faces, but the timeline that was presented holds true for you, but it does not hold true for other sectors. They've moved much more quickly. My world has moved much more quickly, and I'll be happy to respond to any questions that you have on that front when the time comes. We'll let Dr. Flemons give you the story in the language that's more appropriate to you.
Well, thanks very much, Dave, and I'd like to thank Jennifer for the opportunity to come and speak with you this afternoon. Special thanks to Dave and his daughter Terry for coming. This has been a long journey of telling Greg's story, and the reason we told it, and I'm going to share that with you over the next 20 or 25 minutes to make a case for change in a particular area of healthcare around how patients fall through the cracks of our system when they have to be referred on from their primary care home environment into specialized healthcare. So as a background to this, we didn't want to focus just on a single patient's story, because the question is, why this story? But the reason why this story is because it typifies the experience of many others, and as Dave said, perhaps not with such a tragic ending. But over the years, the Health Quality Council has learned through its surveys that it does every 2 years that people in Alberta, and I don't think it's atypical or it's just isolated to Alberta, it's probably every place, that less than 50% of people feel that the coordination of their health care by professionals is actually done well. About 50% report that their physicians never heard about their emergency department care. About 35% report that their physicians aren't informed about specialists or hospital care. And 10 to 15% report that their physicians do not get DI results or MRI scans or don't hear about them from their physicians. So that was sort of the background that said this idea of continuity of patient care is an issue and something that we need to think about. And then Greg's story came to our attention. And the definition of continuity here is the degree to which a patient experiences a series of healthcare encounters as coherent, connected, and coordinated. And I think by the time I get through telling you a bit more about Greg's story, you'll agree that his journey was anything but. So what we're talking here is a small part of continuity of patient care, because this is a huge area. But what we focused on in this one is the journey to specialized health care from primary care. And this is a dangerous time for patients. They leave their security, they leave their home, and especially when their practitioner hits the send button, they're out basically on their own, trying to figure out the navigation system to the specialists. And we're talking, by specialized healthcare, I'm talking about where people go for procedures, where people go to see specialist physicians, or where people get referred for advanced diagnostic imaging testing like CT scans, MRI scans. And what is unique, or what is similar to all of these environments, is that there has to be a referral from a primary care physician, usually, with an appointment provided. There's often a triage step. There's often a period of waiting, or a lot of waiting. There's a service that's provided and a report that's generated and given back to the provider that's referred the patient, and then the patient needs to get to the next level of care. This report also focuses on patients with time-sensitive conditions like Greg had. And by that we meant where diagnosis and treatment should be done within days to maximum a couple of weeks. There's not a firm definition of this in the literature, so this is our definition. And it's because there's a known or compromise of vital limb or organ function, or a high probability of this developing in a short period of time. So when patients are facing the journey to specialized health care, there are lots of cracks in the system and lots of cracks that they can fall through. And the question is, can you use digital health care to seal up those cracks and make it much less likely for patients to fall through the system like Greg did? And so really, what does that bridge to safer health care look like when it comes to continuity of patient care? So this was an in-depth study of the experience of an individual patient, Dave's son, Greg. And what we did is we took information from his patient, from his health records that Dave and his family provided to us. We did multiple interviews in the system, detailed flow mapping. We reviewed the literature. We looked at leading practices in the States, both at Mayo, Geisinger, and Kaiser. We talked to information technology experts, and we looked at published documents like standards of practice that the CPSA published. We did an analysis to inform recommendations to improve the system, and the focus was the system. It was not the individuals that were involved in Greg's care. And so the methodology used was systematic systems analysis, which is published by the Health Quality Council of Alberta, and it really is a methodology for looking at how the healthcare system breaks, and when it breaks, how do you figure out all the contributing factors. And so this was a system-focused approach. We neither looked at or judged the performance of individuals. We focused on issues with broad implications, so not on a few issues or few providers. This case we felt was representative of a much larger issue, and we should be able to substitute many different providers into the story, or we shouldn't look at a case like this, and we thought we could do that. Our recommendations, we were looking for win-win, with a widespread impact and people and being able to assign accountability in order to get something accomplished. This is the report. It came out on December the 19th, and really what it covers is the chronology of the events in Greg's journey. Several lessons to be learned, and we took these from both Greg's families. Dave and his family wrote what they learned from looking at Greg's journey, and we published that, and we also published our perspective as well. And this is just one of the quotes that is in the report from Dave's family. Lessons to be learned, in other words, patients beware. Never ever assume there's a critical smooth handoff between doctors. The report includes 10 findings, 5 major issues that we highlighted, leading to 10 recommendations for change in Alberta's healthcare system, and 1 supplementary finding, leading to 3 recommendations that had to do with our Office of the Chief Medical Examiner, who got involved after Greg died. So let me take you through Greg's journey. And I'm handicapped by not having a pointer I can point at, so you're going to have to listen to my description of the colored boxes. So what this represents, every one of those boxes is a day in Greg's journey. The red boxes represent things that didn't happen. They represent wastes of time in Greg's journey. You can see that there's a lot of red. At the very beginning of the journey is a green box, and it represents the time that Greg went to visit a primary care physician. But let me back up for a minute. This journey actually starts more than 8 months before this timeline, when Greg went to see a primary care physician for a routine physical examination for his pilot's license. And a minor abnormality at the time, it was felt to be minor, was detected in one of his testicles, and it was described as a thickening of his epididymis. Testicle exam was noted to be normal, and nothing else was thought to be made of it. There's no follow-up planned. Greg happened to go back to that doctor for a different complaint, for a skin condition, and that's when this timeline starts. And while he was there, the physician felt maybe it would be a good idea to recheck the testicular exam. Found the same abnormality, didn't think it had changed, and decided he would refer Greg on to a general surgeon for a second opinion. What you see at the very bottom there is a little dotted line with 2 arrows going 94 days. That was the amount of time it took for Greg to hear from the surgeon's office about an appointment. He never had a chance to see the surgeon, so over 3 months. There's about a 38-day gap there, and you see a second green box, and Greg went to see a walk-in clinic closer to his journey to work about some back pain that he'd been experiencing, and as you heard, Greg was an athlete, thought this back pain was most likely pulled muscles, didn't think very much of it. Obviously, whatever he told this walk-in doctor, he was a bit more concerned because he ordered x-rays and an ultrasound of his abdomen. And 7 days later, Greg got those x-rays done, and you can see that in the gray box, and the ultrasound showed that he had a large abdominal mass compressing his inferior vena cava. So suddenly, this was a game changer. The radiologist, to her credit at the time, came out and told Greg what the findings were of the ultrasound and phoned the walk-in clinic doctor to tell him that there was a serious finding, it looked like cancer, and something needed to be done, and recommended an urgent CT scan. Greg returned to the family doctor, but couldn't get there for a week. Actually, it wasn't really a family doctor, a walk-in clinic doctor, and the walk-in clinic doctor ordered the CT scan urgently, as was suggested by the radiologist in the outpatient clinic. That's the third green box, followed by 2 candy stripe boxes. The candy stripe boxes represent where administrative processes were happening, but no actual care process. So the CT scan got ordered urgently. The problem was that the criteria in Alberta for CT scans like this is if you only have a suspected diagnosis of cancer, it's priority 2, and if you have a known diagnosis, it's priority 1. Priority 1 gets done within 7 days, priority 2 gets done within 30 days. Greg's CT scan was done according to protocol. It was done within 19 days. So there's 19 red boxes there. The CT scan gets done after that. And unfortunately, it took another week for Greg to get back in to see the primary care doc, but the primary care doc was no longer there anymore because he'd left the practice. So no phone call. Greg had to phone the walk-in clinic to say, I had a CT scan. It was supposed to be done urgently. I haven't heard anything about it. When am I coming in to see the doctor? He got an appointment at his, by him picking up the ball to see a different walk-in clinic doctor, and that's the purple and green box. And the CT scan confirmed that he had a mass, looked like cancer, looked like metastatic cancer, and raised the question for the first time of possible testicular cancer. Ultrasound of the scrotum was ordered and done the following day, followed by a referral to a urologist in Calgary. Turned out that the urologist was away for an extended period of time for 3 weeks. Nobody knew that. The primary care doctor had faxed the referral in. It sat in a computer fax machine. Nobody attending to it. A week went by. Greg didn't hear about his appointment. Phoned the walk-in clinic. They said, you'll have to phone the urologist's office. Phone the urologist's office. It's the first time it was learned that the urologist would not be around for 2 more weeks. Greg phoned back to the walk-in clinic and they referred him to a second urologist. When that urologist heard what had happened, he moved quickly and got Greg in within 1 business day. That's the last green box on the right. And as Dave has already said, within 2 days, Greg was in the OR getting his testicle removed. In the background, the urologist was talking to the cancer clinic, letting them know about Greg, but the Price family, including Greg, didn't see that appointment actually being made. 2 days later, because of the pressure of the mass in his abdomen, getting worsening swelling and worsening back pain, now on narcotics, Greg felt he was in trouble, and on a normal business day, couldn't reach the urologist who had operated on him. His only option was to attend the emergency department to see a doctor who had never participated in his care before. And the advice that Greg got was, we need to confirm that you have a cancer clinic appointment. That was done in the emergency department. Go home and wait for the appointment. It'll probably be soon. So Greg did what he was told. He returned home, and the following morning he dropped dead of a pulmonary embolism. There's 4 breaks in Greg's care. The referral to the general surgeon that never happened. The follow-up appointment with the primary care doc in the walk-in clinic that didn't happen except that Greg picked the ball up because the primary care doc left. The 3rd break was when the urologist was away for an extended period of time. And the 4th break was when he tried to reach the urologist who did operate on him and couldn't reach him on a normal business day. There was a 5th perceived break, which was, although he was told he had a cancer clinic appointment, he couldn't actually see that it was happening. Had no idea about what the timelines were, and all he knew was that things were getting desperate. So how do you make healthcare systems safer? I love this quote by Liam Donaldson. To err is human, cover up is unforgivable, fail to learn is inexcusable. So the reason we did this study was to learn and try to find out, how do you make this system of referral to specialized healthcare systems safer? So this is a quote from Jim Conway. I need some sound, please.
The fact that we in our organizations have suffering, harm, death, tragedy, near misses, there's nothing about that that discriminates us from any other hospital in the country or the world. Those events happen everywhere. What absolutely will discriminate us is those organizations who have the ability to take the suffering, the tragedy, the harm, and the misery and use those in the name of the patient and the family and staff as extraordinary levers to take an organization to a very different place. The organizations that do that are absolutely discriminating themselves from most other organizations, and they should be applauded.
So in this particular session, we're here in the name of Greg and his family and other patients who we don't know about, who've had similar journeys and similar frustrations. In Alberta, we created this model for making healthcare systems safer, recognizing that really safety comes at the coalface of healthcare encounters that represent providers and patients that come together in that. And that really is the parts of the system, or if you like, the anatomy of the system or the structure of the system. There are functions of the system, and this is what we think drives change and drives improvement. Better designed systems, delivery at the front lines, and the ability to respond when things don't go well, like they didn't for Greg. But absolutely critical to this is what I would call the support systems, the leadership and the principles on which decisions are made in the healthcare system at all levels. And this is described in the Blueprint project at HQCA. The website is there. But there's 6 principles here, and the first one, by design, is patient engagement. That healthcare systems need to be designed with patients as full partners in their own care and in designing the system. But a critical thing here is leadership, and it was mentioned by Richard about how critical this is, and I took this quote from Derek Feely, who's also with IHI. Said leaders have two jobs. One is create a strong vision, and second, constancy of purpose. And I think this is the biggest challenge we have in healthcare systems right now. Where's the vision coming from? And we have a new flavor or new approach every few months sometimes, it seems, in a lot of our healthcare systems. It's impossible to move forward. So this is the challenge. And I think the bigger challenge we have here is in the system, we have lots of access to lots of information now. It's absolutely stunning when I look back at my career. But think about it from the patient's perspective, who's just wondering, why is there this wall that goes up around healthcare information that I can't actually see? And we haven't been very good in Canada at breaking this wall down, and patients are just kind of trying to peer in, look in. And from the patient's perspective, it's sort of like, I'm trying to get over this wall and I can't see anything. I can't participate in my own care if I can't see my health information. So the findings, there's 10 findings. I'm not going to go through them here, but the critical pieces here are the findings that we looked at, the referral to specialists, and around electronic health records. We believe partway through this that the only way to solidify this was to digitize it and get patients the ability to see their own journey. This is the flow process of getting a patient from a primary care provider to a specialist and back again. And I'm going to just blow this up, but basically there's three streams here. There's the patient stream, there's the referring provider stream, and there's the service stream. And the challenge here is that there are so many steps here that can break, it gets to be kind of scary. So in this case, the patient goes to their provider and gets referred for one of these specialized healthcare services, and there's a crack that can exist right there where patients fall through. The referral never actually gets there. The fax doesn't get there, or it sits in a fax machine and nobody sees it. Sometimes the referral isn't correct, so it gets resent and you get rework done. That's not only a waste, but represents another opportunity for another crack for patients to fall through. Once they actually get the referral, a lot of work has to be done in order to actually get the appointment, to notify the patient about the appointment. There's some priority setting, there's some triaging that's done. All of those steps represent potentials for cracks to develop. And wherever there's a crack, patients have a risk of getting lost, and most patients assume no news is probably good news. If I didn't hear about that appointment, it's probably because I don't need it anymore. That's great. I'm busy, I've got things to do. The last piece is getting the patient back to the person who ordered the test in the first place. And once again, more cracks that can develop. So there's multiple different cracks in the system, multiple places where Greg fell through the system and that other patients fall through the system. And this led to 5 issues that we highlighted in the report. And the top one being the reliable continuity of care when patients are referred. So it's the referral mechanism. But 2 others I'm just going to focus on around radiologists and expediting care for patients like Greg, who have a time-sensitive health condition. So those are the 3 areas that I'm just going to focus the rest of the talk on this morning, or this afternoon. So I'm going to focus, though, on the radiologist first. So what about radiologists expediting diagnostic imaging studies in the next level of care for patients who truly have time-sensitive health conditions? I'm not talking about all conditions. I'm talking about people who are time-sensitive like Greg was. Ultrasound shows compression of the IVC. This is not something that should wait. So this is really around priority setting. And just to remind you how long it took for Greg to get from an ultrasound that showed trouble to a CT scan that was sent back to a primary care doc, almost over a month, that turnaround time. So, and what we're really talking about is cutting out the primary care doctor, not because they're not important and not keeping them included, but because what Greg really needed, what a lot of patients really need, is that next diagnostic imaging test or that specialist that can provide definitive care. And so, if we look at it, how we expedite this journey to diagnostic imaging tests and specialists, what we've recommended here is that radiologists should be supported to directly arrange the next logical DI test if it's clearly required for patients with the time-sensitive conditions, and not spend time sending them back to the primary care doctor just to fill out a rec and faxing it in again and allowing more cracks to appear in the system. So this really means direct access to the next level of care and getting through the gatekeepers of who controls access to the CT scans expeditiously or to specialists or to hospitals. So the second piece of this, though, is changing the prioritization criteria for outpatient CT scans. As I mentioned, Greg's CT scan was prioritized 2 because it was only suspected he had cancer, even though there was a 99.8% chance that he did have it. And this is around priority setting, and for this we've asked Alberta Health Services to revise their criteria for how they prioritize CT scans so that patients get in quicker who have time-sensitive conditions. So could this have meant a different journey for Greg? So the bottom graph is the one that I showed you previously. It's how long it took for Greg to get through the system to definitive care. The top graph is what might have happened if we had expedited his CT scan, if we had not delayed him going back to the primary care doctor to go for the one test and then another test and a third test and then over to a urologist. And it's not inconceivable that that could happen in a system that's better designed than we currently have. And it would cut 6 weeks out of his journey. So the last thing I'm going to focus on here, though, is, and I think possibly the reason that the report caught the eye of Infoway, is because really what we called for, the number one recommendation in this report, was to digitize the referral management process, because there's no other way to, in our minds, to actually make this more secure for patients. So again, 4 times that Greg fell through the cracks of the system. So what does this actually look like in getting over this gap and not falling through this crack? So the bridge, and this is what we recommended basically, was that Alberta Health and Alberta Health Services, working together, strongly consider making additional investments in the provincial electronic health record and e-referral system to standardize workflow processes for all specialized healthcare services. And this is including a patient portal so patients can actually see their results and their referral management process. And it focuses on the e-referral system. So when we looked at what's available in the States, best practices we thought, at Geisinger, Mayo, Kaiser. So not only could people view their lab and pathology results real time, they can view diagnostic imaging results, and in short order they'll be able to actually see their diagnostic imaging tests, not just the reports. They can message their healthcare providers. They can see portions of their own medical record, including outlines of current health issues, medications. They can track their chronic conditions and provide updates, and they can enter their own healthcare data and have that seen by their healthcare providers. They can also schedule appointments with their primary care healthcare providers, but they can't actually get involved or see the referral management to specialists. So that's not on their radar at all. They can see their upcoming appointments. They can grant proxy access to family members, so parents for children or for elderly people. They can see their medication lists. They can do pre-visit questionnaires. There's a lot of functionality available, as most of you probably already know. So what about e-referral, though? That's not something we came across in the U.S. systems. And in Alberta, it's the technology solution that enables the end-to-end management of that referral management process that I just showed you. All those cracks in the system tries to navigate over those cracks and keeps them from happening. So all the way from referral creation to the submission to the triage to the direction to the correct specialist. So that's really what we envisioned as a way to solve the cracks that Greg experienced and that many of us experience as patients in the system. So this is just, I borrowed these slides from Alison Bishel in Alberta for Alberta Health Services, who's leading the e-referral project. But their vision, and it's about to roll out in March in a limited production rollout. So it's easily accessible, it auto-populates information, it has a health services catalog, it's possible for people to send advice or a consult, standard referral requirements, checks for completeness, tracks referrals in real time so you can actually track to see how many patients you've referred if you're a primary care physician and what their status is in the system. So it provides ability to search for different terms for results. It allows you to look at potential wait times for different specialists so you can choose first available specialist or specialist of your choice. It allows you to save drafts of referrals. It tells you what you need to submit so that referrals aren't rejected. So it saves a lot of time there. It gives you the standard requirements for triage, so triage people can work with this so they get all the right information first time. They don't have to send referrals back. You can attach labs and images to the referral. You answer questions so that you can do the triaging and saying what's the urgency for it. So tremendous functionality, but importantly, it allows we think, the ability to close the gaps in the healthcare system for referral management. But really what we're asking for, and what we asked for in the report in our first two recommendations, primarily recommendation 1, was that we marry this concept of net care, patient portal, and e-referral, so patients can actually see where they're at in the referral management process, which is actually quite complicated and fraught with dangers. So my last slide is really to come back to, we want to enable patients to be partners in their own care, but our current state right now is you do not have proper authorization in order to see your own healthcare record. So we are the system right now. We are behind a wall, and we don't really enable patients to be partners in their own care. Future state requires a little bit of thinking outside of the box, and I think that's why you're here this afternoon and tomorrow, so what does it take to get to this future state where patients truly are full partners in their own care, and rather than saying you don't have proper authorization, you get a welcome to net care. And you're able to see your diagnostic imaging results when you want to see them. You're able to see all of your, quote, confidential information that you currently can't see now. And importantly, from this report, you're able to track your journey through the healthcare system and find out why it's stalled and what you can do about it to pick the ball up, as Greg did many times in his own journey, but he had no mechanism, nothing to help him actually do that navigation piece. So with that, we're done. I've included Dave and Terry's Health Arrows website there, again, if anybody's interested.